Hello everyone. This is a summary session for Oncology Week. Today we had two essays related to diffuse large B-cell lymphoma and Burkitt lymphoma in the FRCPath Haematology Oncology sessions. You can see the instructions on the front. Please send your answers by Thursday 9 a.m. British Standard Time. No essays after that because I have to print them and then I have to check them. Life is busy, so give me some time to check them. It's better to send it before Thursday 9 a.m., please. And always write your candidate initial on it. Okay? So the first question was about uh, 59-year-old patient who had a big mass in the right inguinal area, and the excisional biopsy shows that the diagnosis is diffuse large B cell lymphoma, and it is a germinal center B subtype. The scenario also mentioned the performance status of the patient is 2, and no other information was given about patient testing like LDH, extranodal site involvement, etc. So the first question was, what is the expected immunohistochemistry marker in the patient? Most of the people have written the marker correctly, but when you are asked what are the markers, you should say CD5 positive or negative. Okay, CD10 is positive or negative. Mentioning only CD5, CD10, CD19, 20 does not make sense. Right? CD5 is negative, CD10 is positive, 19 is positive, 20 is positive, BCL2 positive, 6 positive, etc. Whatever the markers are, mention all of them. And the second question was, what is double hit and the prognostic factor? So double hit is easy if you have any of the two markers present, MOIC, BCL2, BCL6, and TP53, this is double. Prognostic factors, better to divide them into patient-related factors and disease-related factors. And you can apply this in all hematological disease when they ask you what is the prognostic factors, what are the prognostic factors of this condition. Okay. Then disease management. Um, this is a DLBCL case. Management always starts with clinical assessment, history, and examination. Then you have to mention all sort of investigation that we do in a DLBCL patient, and then consultation with the patient to explain what is the result of these investigation and what you are going to do next, which is uh, chemotherapy to start in this patient. Discuss the patient in MDT. Do not forget fertility preservation. Inform or mention the treatment options. Like you have two treatment options in this age category, which is R-CHOP and polar R-CHOP. Depending upon IPI scoring, I will suggest either R-CHOP or polar R-CHOP, which will include interim PET scan as well and end of treatment imaging. Because at the end of treat, if the interim PET scan is positive, then you will do end of treatment PET scan. If the interim PET scan is negative, then you will do end of treatment CT scan. This is a high-grade lymphoma. Never miss TLS management in the patient because if you miss TLS management in this patient, this is a blunder. And do not forget follow-up, please. This is important part of the management of any hematology patient. We do not abandon patient after giving him first cycle of chemotherapy. Do not write your answer in paragraph form. Better to write the answer in uh, bullet points with headings, please. Okay. Clinical assessment should be the first heading. Then under the clinical assessment, part A is history, part 2 is examination. Then second heading should be investigations. Mention what investigation you will do. Then third heading should be consultation. Tell the patient what is the result of uh, investigation, what is the diagnosis, breaking bad news, give him psychological support, give him leaflets, mention MDT fertility preservation set. Then give a heading of treatment option. Okay. Then give a heading of the um, follow-up section. Okay. So this will make your answer more logical. Then outline new updates in DLBCL. This is an era of bispecifics. To mention the two bispecifics that are now approved and widely used, glofitamab and epcoritamab. Also mention CAR-T, which is second line in DLBCL, and mention the Lotus trial as well, loncastuximab, which is newly approved for DLBCL. Then the second question was about a young female Burkitt lymphoma patient with high LDH and positive HIV serology as well, and Chi67 was more than 99%. Giving a young patient in the scenario means you have to check for the possibility of pregnancy. Pregnancy testing is must in such scenarios. If you forget this, it may harm your essay in the exam. So please mention pregnancy test in the in the in the investigation section of your answer. Then the first part was what are the complications associated with this disease management. So disease-related complications and treatment-related complications. Disease-related complications is the osteonecrosis of the bones. If the disease invades the bones, you have osteonecrosis. Burkitt lymphoma is known to cause osteonecrosis of the jaw. If disease invades renal kidneys, the patient presents with obstruction, hydronephrosis. The disease mass can compress vasculature, leading to DVTs, can compress nerves, leading to neuropathies, can invade bowel, causing perforations, etc. Treatment related, if you are using orthodox MRI VAC, so methotrexate induced hemorrhagic cystitis is common. So sorry, the cyclophosphamide induced uh, hemorrhagic cystitis, methotrexate causes renal problem. Okay. Then management of this patient again, just like for DLBCL, this management should be in bullet points with headings. This patient was having pain and vomiting, so give an extra heading of immediate treatment or immediate intervention, which will be uh, antipyretics and analgesics. And then clinical assessment, history, examination, the investigation heading. Okay, all the investigations you mentioned what you would like to do, pre-chemotherapy investigations, including echo, PFTs, etc. Then you have to uh, mention consultation. Okay, inform the patient with the diagnosis and your treatment plan. Mention MDT, fertility preservation. Okay, and you should mention pregnancy test in the investigation section as well, and then follow up. This is a high-grade lymphoma as well, so you have to mention TLS prophylaxis in this patient. Right? Then treatment, the patient electrolytes got deranged, so these are the features of TLS. So if the patient develop TLS, it is a high risk condition. You always enroll an MDT consisting of ICU, renal team, and cardiology team because the patient need high level care in the ICU. She may need filtration or dialysis for electrolyte derangement and renal involvement. The patient will need 24-hour monitoring, treatment doses, respiratory case, IV fluids. So all these treatment can be done in the ICU setting. And TLS always involves an MDT management by renal team, by the cardiology team, and by the ICU team. So then this is the summary section, and the summary section will be uploaded to the YouTube for all and the actual detailed section is for the members only. You can become a member by clicking this link, and you can see the uh, uploaded recording on the website as well. This is the website link, and if you want to donate, use this donation link. Thank you.